Hello, everyone, and welcome to the symposium and the first panel discussion, where we're going to really set the ground for the rest of the work that you're going to be hearing over the next 2 days. So in this panel discussion, we're going to be talking about health and healthcare challenges facing our state. I'm going to give a little bit of an overview, and then I'm going to introduce our panelists, and they're going to give their perspectives. So what I want to do, though, is start with a little bit of the history of health in North Carolina, because I think it's really important for us to know where we started from, see how far we've come, and then to put the challenges that we're facing today into perspective. So I'm going to go back to the 1940s. Many of you know about this in the 1940s. But North Carolina had the notoriety in the 1940s after World War II of having more men rejected for health reasons in World War II of any state in the country. And that led our governor at the time, Governor Broughton, to create a commission to try to figure out what was going on in North Carolina that we had so many people rejected for health reasons. And that was a hospital and medical care commission, and it led to something that was known as the Poe Commission, because Poe was the doctor who was, actually I don't think it was a doctor, who was in charge of that commission. And the commission, the Poe Commission, created the Good Health Plan. So I'm going to do the same thing that we did before, which is how many of you have heard of the Good Health Plan in North Carolina? Only about less than a quarter of you. You have a treat. Hopefully we'll hear it later today. I don't know if we will or not. But if you haven't heard it before, you should go and Google Frank Sinatra and Dinah Shore, It's All About You, because there was a song done about the good health movement in North Carolina, and it's really fun. But the Poe Commission came up with a series of recommendations, and the reason I put it up here is because when you look at that list, you're going to see how many of them are still plaguing our state today. They said we needed more physicians. We needed more hospital beds. We needed greater affordability of care and more health insurance coverage. We needed to address health disparities. We needed more community resources to address the needs of people with mental illness. We needed greater funding for public health, and we needed a school health program. And if you think about what Governor Cooper said earlier today and what the Secretary said, so many of those issues we are continuing to work on right now. So I'm going to fast forward us to the 1960s or 70s because I want to highlight something that came up earlier in the discussions, which is that we are a state of innovation. In order to address the primary care shortage, North Carolina was the first, Duke had the first program in the country for training physician assistants. It grew out of Duke. Around the same time, we had one of the first nurse practitioner programs in the country. So we were at the forefront of training non-physician clinicians who could address the healthcare needs of our state. We were the first state to pass innovative health legislation at the time in 1975 to allow nurse practitioners to practice. We are now a little bit behind the curve in terms of nurse practitioners and scope of licensure, but at the time, we were at the forefront. We created the first state office of rural health in the country to try to address rural health challenges. We were one of the first states to create an area health education centers program to help continue education for practitioners. Again, that grew out of the Poe Commission and what the Poe Commission recommended. And then, of course, we created CCNC, Community Care of North Carolina, which is an award-winning Medicaid care management program that really helped launch us towards improving the quality of care we provided to Medicaid recipients and to link them with a medical home. So we have been innovators, and we did that through collaboration between the professions, between communities, in order to address these problems. But we still have challenges that we're facing. As a result of our past efforts, we did put more emphasis on expanding the health professional workforce, but we still lack primary care providers to meet the needs across the state, and dentists, for example. If you take a look at overall health professional shortages, we don't fare as poorly as we do when you look at geographic distribution. We have a significant problem with maldistribution of health professionals. North Carolina is not unique in that regard, but you can see from the slide that we have 82 counties that are considered either in whole or part a primary care shortage. We have too few primary care providers. We have 84 counties that have too few mental health providers and 74 counties that have too few dental health professionals. And then, of course, we've already heard about the fact that North Carolina has not expanded Medicaid. So North Carolina has one of the highest uninsured rates in the country because of that, of the fact that we have not expanded Medicaid. Our clinical care system is good overall. If you look at the Agency for Healthcare Research and Quality, they produce a report card that looks at how we are doing on clinical care. And you can see that there are many areas where we are well above the national average in terms of person-centered care, care coordination, acute care, chronic care management. I think a lot of that came out of the work from CCNC and some of the other initiatives we've had in the state. But we have other areas where we have still challenges and where more work is left to be done. Now this chart is a little bit harder to read. It comes out of Health Affairs. It's a recent article that came out of Health Affairs that shows how North Carolina is doing compared to other states in new model innovation, adoption of new models. In this slide in particular, it's how many ACOs, accountable care organizations, we have in the state, and how many people are covered by that. And it shows when you can sort of try to discern the difference in the color of the blue, that North Carolina is slightly above average in both regards there. So clinical care is not our problem. Stepping up to innovation is not our problem. Where we have our problem is in those non-medical drivers of health. We know from the work of Mike McGinnis and from the work that's followed from the county health rankings and Robert Wood Johnson that only about 20% of people's health outcomes are really attributable to the medical care we receive. So much more is due to the social and environmental factors, the physical environmental health factors, and health behaviors that we engage in. And when you look at our data, this is where we really have to focus our efforts, and that's what's so exciting about what the state is moving into with healthy opportunities. We are 40th in the percentage of children living in poverty. We are 35th in health disparities. We are 45th in median household income. And that leads, of course, to poorer health outcomes, where we also are at the bottom of infant mortality, of low birth weight, and of premature deaths. So the takeaway is that North Carolina has both great strengths and many challenges we have to face. We have a history of innovation. We have a history of collaboration. We have quality clinical care. We are willing to and have historically been innovators in new care delivery. And all the work that you've heard about with Medicaid transformation, I think, is going to really move us forward. But we have significant challenges that we have to face that we've already discussed. So now let me introduce our panelists, and the rest of the time we're going to hear from them, talking about both the strengths and challenges that our state faces. First, I'd like to introduce Karen Smith, who is to my left. She is a family physician, and she is a medical director of Alade's North Carolina ACO. Then to her left is Steve Neorr, who is the Senior Vice President of Population Health at Cone Health, and the Senior Vice President and Chief Administrative Officer for Triad Healthcare Network. And then to his left is John Lumpkin, who is the President of Blue Cross and Blue Shield of North Carolina Foundation and a Vice President of Drivers for Health Strategy at Blue Cross Blue Shield of North Carolina. So I'm going to turn it over to them. I've asked them each to give about 5 to 7 minutes in introductory comments and really to say from their perspectives, what do they think are the strengths of the state and what are the most pressing health and health care challenges facing our state? So Karen, I'm going to first turn it over to you.
Perfect. I do appreciate the opportunity to be here. The best time to practice medicine is when we have the opportunity to make a difference in someone's life forever. 32 years ago, I took the Hippocratic Oath of Medicine, and those words were inspiring then just as much as they are inspiring today. The physician navigation journey through North Carolina's healthcare transformation needs us to think about what are the best physician characteristics? What do we have now? And then to take those physician characteristics and realign them with trend-setting strategies such as TOPS, technology, opportunity, options, people-pleasing, scalable, and strategic. And then, what is our best solution? The affordable care organizations. How are we utilizing those entities? And then finally, to realize our prize at the end of the road, which is that comprehensive care in North Carolina. My journey begins at the age of 6 years old. I was playing in my parents' home, and I fell down the basement steps, plunkety, 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 plop. And I woke up, and what did I have? A deep laceration on my perfectly smooth skin. Well, fortunately, our family doctor was at our home at that time. He was there caring for my sick mother. And so our pulmonary medicine family doctor went into his black bag and he sutured my chin at the home. Perfect suturing. But he left a scar on me which has remained forever. And that was a scar of the physician's compassion. As we move forward in North Carolina's transformation, we recognize that that family doctor, that pulmonary medicine specialist had the best characteristics of a physician. He was accessible, his quality was good, but he sacrificed cost and efficiency, what many of us know as the quadruple aim. And that is a challenge that many physicians face now as we attempt to integrate those principles in our daily practices. We're trying to implement those strategies for population health-based medicine for the treatment of chronic diseases. We also want to make sure that we are paying attention to preventive health, including that of vaccinations. In addition, we recognize the importance of social determinants of health, but we also recognize the need to continuously deactivate implicit bias. And what about meeting the crisis of the day, the one that we continue to work with, the opiate epidemic? And so physicians are currently straddling between the world of the traditional fee-for-service and value-based payment models. And so we continuously seek solutions. And the solution that we have come up with, the acronym TOPS, technology, opportunity, people-pleasing, scalable, sustainable. But when you say technology to a doctor, we immediately think of our electronic health record system, and many of us already begin to laugh at the humor of too many clicks, too much consumption of time, and way too much cost. But then we do start to feel better when we think of the state-based health information exchange system and our bidirectional portals with our patients. And then we look at that and find some physicians are utilizing that technology for direct primary care practices, and they're starting concierge businesses. And what about our vaccine purchasing businesses, such as the VaxCare Corporation that's coming into the state? But then our people-pleasing opportunities. We finally can utilize our little devices of our smartphones and use those to actually have secure messaging with our patients. Our patients can now hear us and we can hear them. We can now act on their needs for what they have told us. And guess what? We finally put the patient back into their own care. And so that's what we're talking about. But then we need to make sure that we're utilizing sustainable efforts. So we need to enhance our leadership in our own home, in our own patient-centered medical homes, as well as make sure that our staff have proper education in terms of health information technology, that they are Google savvy. And then we want to make sure that we continue to have those businesses that are sustainable. By the way, those new practice trends are actually bringing those patients, those doctors who left the traditional fee-for-service are coming back into the joy of independent practice. We move forward, and we still recognize that the value-based payment model system is a little bit of uncomfort for doctors. So we're still continuing to look for solutions. And we come up with the affordable care organizations, and some of us were entertained with the clinically integrated network. But before we even had that, we had the community practitioners program a long time ago from the North Carolina Medical Society Foundation. And we trusted that program. And that program allowed physicians to go into communities where there were too few of us. And we recognized the value of that program. And so now we have affordable care organizations that have come onto the environment, come into our basic business plan, and we embrace them. And one such is that of the Alidate organization. And Alidate, I like it. Alidate keeps it simple, they keep it real, they keep it moving. And because of that, their basic tenet that we can see on our slide is what's good for the doctor is good for the patient and good for society. Alidate uses high-touch technology, people on the scene in our practices, as well as they have introduced business models that allow us to remain in practice, business investments that we did not have before. And so as we move forward in terms of what is transformation in North Carolina, healthcare transformation for our practices, one of the things that we keep in mind is, yes, we had the quadruple aim. Quadruple aim was merely stepping stones. And now we are moving forward through our investments with the ACOs, with the CINs. And those are the ideas that lead us to TOPS. And from that, we feel like we will be able to obtain those healthcare systems in regard to transforming North Carolina's medical systems in our offices. Now envision the 6-year-old girl in the home of her 92-year-old visually impaired patient. He held my hand and he said, "You are a miracle maker because you are able to take the ordinary and create the extraordinary." And I say to each one of you, become miracle makers for the sake of North Carolina's healthcare transformation.
John, I don't want to follow that. Thank you, Dr. Smith. I've got an admission to make. Let me see if I got my slides here. I've become an expert. Let me say this. I work for Cone Health. For those of you who don't know, it's a 6-hospital system based out of Greensboro, about $2 billion health system. And I was brought in about 7 years ago to start up at the time what was called, it wasn't even an ACO, it was just the CIN. And population health wasn't a term yet. It was just an idea. And quite frankly, it was really about they wanted a way to partner with physicians outside of employment. That's how this got started. So they brought me in. I had led a physician group out of Texas. I came in. They didn't even have an office for me. They had a spare conference room. They led me in and said, "Go do it." And so I've become an expert over these 7 years of really what not to do. And so here I am today. But it's been really a great lesson of how things can change. And one great example is I work for a hospital system. A hospital system, and I can promise you, I have to give a lot of credit to our leadership when they brought me in, because they really believed that there was a different way. And so did the physicians, that the current healthcare system just didn't work. And so from the beginning, we always were a little bit at odds with the hospital, because now my team has grown to almost 200 people, between nurses and pharmacists, everything else. And my team of people do something every single day to keep people out of the place across the street. So we're always at a little bit of conflict all the time. When they send out the daily census, and as a hospital executive, I promise you, my reaction to a high census is very different than the hospital president's. It just is. It just goes to say. So but it's been a journey, and it's been a lot of fun, and we'll kind of share some of those things here. But to answer the question, so what are some of the strengths? I've been here for now 8 years. It's hard to believe, and a lot of these we've already heard from Governor Cooper and Dr. Cohen. Obviously, we truly believe we have a great local public health system. We have a really unsurpassed, I think, education system here that really benefits in terms of both our providers and our professionals. I will say, Pam, I would give us a mark. I think we're way above average in ACOs. I think there's only about 40 next-gen ACOs in the country, and these are organizations that take full risk. We have 3 of them right here in North Carolina. Almost every major health system in the state is an MSSP. So I would say that we are way above average, so no offense. And one thing local I'd like to call out is, at least in our market, we're seeing much greater connection with our public and private partnerships. And this, I like to call out the one, the Get Ready Guilford initiative. We've already raised over $30 million, and people in our community is really interested in early childhood education. The challenges, again, I think we could go on and on about those. We've heard about a lot of these. I would like to point out this whole idea of access to quality affordable health care. One of the things we focus on every day is really how do we lower the cost of total medical cost while improving quality and outcomes. That ultimately, when people talk about what is our mission statement or what is my commander's intent, that is what we focus on every day. It's really quite simple. And one of the things that drives me crazy about our current healthcare system is, I'll give Kona as an example. Everyone's trying to be more efficient and cut costs, and we have this big initiative called operational effectiveness, and I give them credit for that. And then I look on their books, and they publish their community, how much they spend, and we spend $425 million in uncompensated care, just with Cone. And I ask, after they're kind of looking for the nickels and dimes throughout the system, I said, who's managing that? What is the answer? No one. And the answer, it will come to why that is. And this is one of my favorite quotes. And if anybody's heard me speak, I have it. I try to slide it in almost every single deck. And this is it. Because you're going to hear different perspectives from a health system, from a provider, from a foundation, an insurance company. And one thing we'll all say the same thing. We all know the problems. We all know what the issues are. And yet, for whatever reason, it's like a mystery why we just can't make the change. And this quote, to me, summarizes it. And this is from Dr. Patel in 2006. And he says, every system is perfectly designed to get the results it gets. So I would make the argument that our system is working perfectly. We just don't like it. Our system is perfectly designed to deliver high-cost health care without any accountability for quality or outcomes. That's what we get. And I'd like to share you a simple example. And this should get you mad because you all participate in this. Most everyone here has got a job, I'm assuming. And if you look at your paycheck very carefully every 2 weeks, you have a little deduction for Medicare, about 1.45% of your pay. Promise you, it's there. And most people don't realize that 1.45% it actually goes to fund Part A, the hospital fund. And so when you hear this idea that Medicare's the trust fund's going broke by 2026, which it is, that's really what's happening, is we don't have enough people paying in out of their paychecks, that 1.45%, to cover Part A. Well, part of being an MSSP, being next gen, we get claims data. And for those of you that have never really looked at claims data for 30 or 40,000 people, it's pretty interesting stuff. Then you start really realizing how big a problem this is. Because what you start realizing is, as taxpayers, who you're funding this, we start noticing we got people going to the ED 30 times, 40 times, 50 times, 60 times. Our record breaker is still today is a lady that went 132 times in 12 months. And you're looking at this, and you're like, how can someone go 132 times a month? How can someone go 60 times a year, 132 times a year? And the question is, it's real simple why that happens. There is no one, there's no one in this system, it's not incented to stop it. This is a woman, and so we had a nurse went out to her home. It was a person in a wheelchair in a home without a ramp that had not been a primary care doctor in 3 years, had rampant diabetes and no refrigerator. So guess what? Anytime she was lonely, anytime she was hungry, anytime she needed anything, who did she call? EMS. Design problem. Where does EMS take you when you call them? Hospital. Why is that? That's the only place they get paid to do it. It's a payment problem. It's a payment design problem. So guess what? When she calls EMS, she's going to the hospital, And guess what? When she goes to the hospital, they get paid for that. So there's no one there to fix that. And so what did we do? We sent out a nurse, and we realized, guess what? So how does it work with our arrangement with the government? They basically said last year, we'll give you $263 million. If you spend less than that, you get to keep it. If you spend more than that, you got to pay it back. Guess what? If I went back to our health system and said, your margin is now based on keeping people healthy, what would they do different? Everything. Everything. Absolutely everything. Because in our perspective, we looked at it and said, what would we do different for this lady? Guess what? Is it worthwhile to build a ramp in her home? Yes. Is it worthwhile to pay for a refrigerator? Yes. Is it worthwhile to hook her up with transportation and do education for her? Yes, yes, yes. And yet in the current system, that is not incented. And who paid for that? We paid for it out of our pocket because we knew if we stopped her going to the ED, we'd get the savings. That is the fundamental difference. And that's what's so exciting about these changes that we've get to be a part of here. One last thing. Changing the system, I'll say this is my one last thing. There's one quote from Don Berwick. I believe this wholeheartedly. Everyone plays a part, but at the core, providers have to change this. I love this quote from him. If improvement is the plan, then we own the plan. The government cannot do it. Payers cannot do it. Regulators cannot do it. Only the people that can give care can change it. And so we have to make the incentive. We were talking about Dr. Cohen aligning those incentives. It has to align with providers. Thank you.
Great. So I get to follow you. So I'm going to talk about the work, and as you've heard, I've got two hats, so I'm going to shift from one hat to another when I talk about some of the work in the company as well as the work of the foundation. And the mission of Blue Cross Blue Shield of North Carolina is to improve the health and well-being of our customers and communities. And you're going to hear a lot about some of the initiatives that we're doing on value-based purchasing with other speakers. I'm going to focus on the issue of communities, because the health of our nation, the health of this state, and the health of people is determined by the health of the communities where they live. Now, when you look at the data from North Carolina, and Sig, it's good to see you here from Wake County, because Wake County is the healthiest state in this nation on the county health rankings. And if every county were as healthy as Wake County, North Carolina would be the healthiest state in the nation. But that's not the case. Just 5 miles from here, 5 miles from here, where Wake County is, but in this particular zip code, a distance of just 5 miles is reflected in an 11-year difference in life expectancy. So as we begin to look for solutions, we have to look into our communities. Because when you look at the way people spend their time, there are roughly 500,000 minutes in every year. And people spend about 120,000 of those minutes working, 93,000 watching TV, 27,000 eating and drinking, 15,000, 16,000 shopping, 7,000 on sports and exercise. That's a problem right there. And only 60 minutes on average in this country in a clinical visit. So health happens where people live, learn, work, and play. And this isn't new. Karen talked about her Hippocratic Oath. But one of the things that Hippocrates said 2,600 years ago, that if you want to know about the health of the people, you look at the air that they breathe, the water that they drink, and the communities where they live. Because these reflect the choices that influence people. My former boss at the Robert Wood Johnson Foundation, Risa Lavisa-Mori, said that the choices people make are determined by the choices that they have. And let's think about that. Those of you who came from out of state, you were in an airport, and like most every other airport I've been in, this is what you see when you have a choice for food. It makes it really difficult to make a healthy choice. I actually was in one airport, and I saw this thing that said fresh green, And I said, okay, I'll go there to get something to eat because even though it's all the way on the other side of the airport. And I walked all the way over there, and it was a florist shop. Now, the good thing about that was I did get some exercise. A few years back, I was in Zurich at the airport, and this is what I saw. The opportunity to make the healthy choice when that's presented versus what we typically see in the airport are the kinds of choices that we have as a nation. Now, Rocco Perla from the Health Initiative has looked at some of the data related to North Carolina, looking at the health in our counties. And we begin to focus on how we see health from a health care perspective, from a health cost perspective. When you look at each one of those dots is a county, and we look at, on the average, a person living in that county, how much money is left over after they pay health care expenses, then you might make the assumption that we're doing pretty good. But the reality is that people also have, they have to pay for food, they have to pay for housing, they have to pay for transportation, they have to pay rent, they have to pay child care and taxes. And when you do that same analysis, almost every single county in North Carolina is in a deficit situation. People have to make difficult choices. A choice between, and I'm sorry this didn't show up, but they have to make a choice between housing, transportation, healthcare, or food. And all too often, food loses out. That's why we have a problem in this state. We are the 8th largest agricultural producing state in the nation, and we rank 48th in food security. Wow. We have a challenge. And when you begin to look in North Carolina, the impact upon healthcare is dramatic. When you look at the same counties and you begin to rate them and look at those counties that have food insecurity, we see increased medication non-adherence. And further, when you look at food deserts in counties, those that have more food deserts also have increased medical expenses. So these are problems related to where people live. And I was glad that Steve showed the slide from Paul Batalden that showed that quote that said, every system is perfectly designed to get the results that it gets. And the systems that we have in North Carolina are systems that are decades in creating the problems that we're trying to address. This is Greensboro. Greensboro is about 50, 60 miles away. And what's interesting about Greensboro, and this is thanks to the University of North Carolina in Greensboro, this is a map of Greensboro that was designed in 1936, and it talked about where to invest money in housing. The red dots are where the term redlining came from. And yellow are the areas that were next. The green were the best areas. And when you overlay that same area, now imagine the same area and look at this particular one. There's a lot of colors on here, but just say the darker colors means that high income, high housing value, and the paler colors, low income, low housing value. Exactly in the same locations as the redline communities 70 years ago. And then when you add in concentration of racial poverty, the same areas that we saw earlier on in the redlining. Redlining is a system that is imbued, a system of racial inequality that has to be overcome if we're in fact going to improve health outcomes in the state. So when we look at the drivers of health related to food insecurity, and you say, well, let's look at it compared to health insurance, there's not a strong correlation, and these are, again, from Rocco Perla at the Health Initiative. When you look at income, because we know income is directly related to health outcomes, there's a much stronger correlation. But in North Carolina, the strongest correlation is based upon race. And that when you look at the percentage of African Americans in a particular county, the larger the percentage, the more likely they are to be food insecure. So to make a difference, we need to address the issue of health equity. Health equity is that everyone has a fair opportunity to be as healthy as possible. And you may have seen this, this infographic from the Robert Wood Johnson Foundation, that the difference between equality, that is everyone gets the same thing, and equity is that people get what they need to be healthy. And this shouldn't be a new concept for those of us who are clinicians, because we know we don't give every patient the same dosage of insulin. We, in fact, titre their dose based upon where they live, their activities, and how they live their lives. And that the key issue and vital directions raised for this, as we think about making these solutions and addressing health equity, is that we have to listen to the voices of communities. This is Paula Avery. Paula Avery is part of the Community-Centered Health Initiative of the Blue Cross Foundation. And her changing moment, the thing that really transformed for her, was when someone asked her, what's the vision for her community? And her answer was, gee, I never even knew I could have a vision for my community. And when communities begin to develop visions, then change can happen. Paula Avery's vision was setting up a community garden. And we have been working at the foundation with communities across the state, each one developing partnerships of healthcare and community organizations, but with people who are involved in the communities taking the lead. It is that kind of leadership that can make a fundamental difference. And when you go back to Greensboro, that coalition there, working together with the University of North Carolina in Greensboro, the Housing Authority, community organizations, and healthcare organizations began to address the issue of housing. And after 5 years working together as a coalition, not only are making progress on that, but they're also addressing food and healthy exercise. We think by working together between the foundation, the company, other philanthropies, Laura, I see you out there, and the Department of Health and Human Services, that our foundation's mission to improve the health and well-being for everyone in North Carolina, making North Carolina one of the healthiest states in the nation in a generation, is possible.
So I'm going to switch up the order a little bit, and I'm going to just ask a couple of follow-up questions to ask them to probe a little bit deeper into some of their main points. And I'm going to start with you, Steve, because as I said, I'm going to switch the order a little bit. So I've had the opportunity to hear Steve talk a couple times because Steve's organization did help create one of the first ACOs in the state, and it was a highly successful ACO, but I've heard him talk on numerous occasions about the fact that what they really need to be doing as a health system is investing more in upstream social drivers of health, and that it's been a challenge. He gave us an example in his opening remarks about how with that one person, they did invest in upstream social determinants and addressing the isolation needs of that individual. But I want you to talk a little bit more about what will it take to get a whole health system to really move upstream and start looking at what are the real drivers of health and not just the medical care that we're providing or not providing.
Sure. One of the things, and I have to give Kathy Colville credit for this, she came up with this idea of mainstreaming of social determinants. I'm going to hijack that and call it mainstreaming of social services. I think one of the biggest mistakes we make is when we talk about social services, even in these contexts here, we think of it in terms of Medicaid patients, we think of impoverished patients, homeless patients. And I will tell you that one of the nice things about NC Care 360 was the fact that we got to go out to our primary care offices and implement this. And what was shocking was, for most of our primary care practices, they had no idea of these available services in the community. If you did not have a primarily Medicaid practice, had no idea. So what we realize is there is a socialization here that we had to start making, and I have to give a lot of credit because it really was the NC Care 360 that really we started introducing this, and they're like, oh my gosh, this is available? Yes, it is. And so it's been a really great way to do that. From that perspective, a lot of it's just doing education with our practices about what's available and helping them along. We were just, like I said, somewhat surprised by the folks that just aren't aware of those particular services.
So let me turn now to John. John, you talked a lot about sort of place-based and the differences in health outcomes between in Wake County, the 11 years difference in 5 miles, if I remember that correctly. And you talked also about disparities. The last slide you showed was the strong correlation between sort of health outcomes and race. What do we do as a state? I mean, it's great to invest in a particular community, but how can we move the needle from a state perspective and really start addressing health disparities and health inequities in our state?
The critical task as a state is to identify and support our communities. I believe, and I was state health officer in Illinois before I went to the Robert Wood Johnson Foundation, that the role of state agencies were to create the conditions in which communities could be successful. And I think that when we look at, as a state basis, where are the barriers and where can we facilitate change at the state level? Let me give an example. I talked about food insecurity. One of the barriers that exist around food is that because regulations are in place, local growers can't sell to schools unless they have certain certifications, which becomes cost prohibitive for those growers to be able to sell to those local communities and local schools. So removing those kind of legislative barriers and providing support to communities.
So let me come back at you one more, and then I'm going to turn to Karen, which is, I think that makes sense in certain contexts, but how do we have a problem with disparities in wealth in our communities? Some of our communities, like Wake County, is pretty wealthy. Some of our communities, like Bertie County, isn't. I happen to be on the board of Alliance Health Plan, and during the last hurricane, they were talking about how they were lucky because Fayetteville had housing stock where they could rehouse people after they lost their homes. But that some of the other communities that were affected by the hurricane didn't have housing stock, and they don't have the wealth in those communities to build housing. And we talked about, I think, I can't remember whether it was, I can't remember the analogy that we talked about earlier, but there's a movement of housing first. In order to get people into housing is one of the critical factors to address social determinants. So how do you, in a state that has this unequal wealth and unequal ability, how do you rely purely on communities to do it? What else do we need in order to address some of those challenges?
So I'm going to start off saying, number one, we need to expand Medicaid. Number two is that as we think about ways that we improve our systems, we give concern to our local communities. So you take Asheville. We, as a foundation, supported the Mothering Asheville as an initiative as part of our community-centered health. And what they did was they were addressing infant mortality disparities in Asheville. And when they addressed it, they developed a doula program, and they hired women from the community, and they trained them to be doulas. So the care that was being provided in the community didn't come from outside. It came within the community. That led to economic development. And as we think about Medicaid transformation, as we think about shifting to value-based purchasing and partnering with health systems, the emphasis on using local resources and building up and supporting the capacity of local nonprofits to provide these services, rather than having a company from Philadelphia coming in to deliver meals. I think that's a critical aspect of the kinds of transformation we need that builds local economic development and stability into the system.
Right. Karen, you've been one of the most articulate spokespeople I know for many years about the role of electronic health records and using data systems to really understand your patient population and to really connect them with care and provide high quality care. But what we heard earlier today is the challenges physicians still experience in using these tools to try to improve health. And now we're adding a new layer on, which is the NC Care 360, which will be in the electronic health records to help connect them to social services and other human services organizations across the state. How can we help work with practices to make sure they're ready to fully engage in sort of the new practice reform and help patients get the care that they need to address all of their health needs?
The practices are now seeking solutions which we're finding in the affordable care organizations, as well as our clinically integrated networks. We are also finding solutions on the state level as well as the national level. So what I'm getting to is fragmentation in terms of our solutions. And how do we get everything on one platform? The affordable care organizations have helped us to understand what are those measures that matter and how do we teach our staff and our teams in terms of recognizing those measures. We must make sure we're gathering them, that we're collecting them, and then to be part of an ACO that has a high technology platform that can accept those measures, use that information, and allow that information to now go back into the community for the patient. But I wanted to highlight a project that is part of the American Academy of Family Physicians, and it comes through our Center for Diversity and Health Equity. It has been recognized on a national level, therefore the education has already gone out to those physicians who are part of the organization. But they recently released a Gravity Project. And the Gravity Project is utilizing the longest acronym I will use this year, HL7 FHIR Accelerator Program. Okay, what in the world is that? And basically, it is an advanced data exchange system that now allows us to utilize the language, the metric that can be captured in an interoperable system, which is also recognized in our electronic health records, which will also be identified in our ACO platform. Finally, we are speaking the same language. So we're taking the basics of food insecurity that we have been told by a patient in the office. We are now converting that to a metric. That metric is now being measured in our systems, and we can now look at our data and put it back into the communities. So what I have just said to you is we are getting beyond the problem of interoperability and getting beyond the problem of fragmentation so that we can get to the solution for the patient.
Can I ask you a follow-up question? Because you're the expert here. So one of the challenges I hear a lot about, and this really gets to a question that Secretary Cohn was talking about, one of their goals was to integrate behavioral health and physical health. But we have these firewalls that have been built in because of the federal level of us being able to share behavioral health or in particular substance use disorder information across providers. I'm wondering if you think that there are solutions to how we can address that so that a provider really can address the whole patient care rather than still staying in these silos of this is physical health versus behavioral health.
And I appreciate that question because we are working with a pilot project with the North Carolina Medical Society Foundation, which is Project OBOT. And that project is layered on the recovery platform. The recovery platform not only allows us to bring the patient into the practice, brand new individual. I had one yesterday, used heroin for 45 years. And now we can bring that patient in. Their information is actually captured on the recovery platform as part of Project OBOT. I'm able to see that patient. I'm able to provide the medication-assisted treatment for him. In addition, the care coordinators are able to access that information. We have a psychiatry consultant available to us, as well as LCAS, and I can utilize the urine drug screening information and access the PDMP, which is the state and CDC recommended tool. All of that is on one platform. There are no firewalls on that platform because there's an agreement and it's a collaborative and it works well. And that one patient will be coming back to our office for induction next week. So we are utilizing that information without barriers of the firewall.
Okay, I think we're coming to the close of our session. We have about 10 more minutes. I'm going to ask the panel to really briefly, if you had one policy solution that you could raise with the state. We've already got the Medicaid expansion. I think all of us up here would agree with that. But if you had one policy solution that you think could make a huge difference in terms of improving the health of our state, from whatever lens you want to take it from, what would the policy solution be? And I will leave it up to the three of you to decide who wants to speak first.
I'll go first. So the one policy solution that I would suggest is certainly looking towards decreasing the fragmentation. As a physician, I feel like I'm pulled in multiple directions, and if I can get it all together in just one day, that would be wonderful. Can I accomplish what we set out? And I'll also say, as we develop policies, make sure that we pay attention to implicit bias from the institutional level all the way down to the individual practicing level. I feel like that has been a great hindrance to much of what we try to accomplish. So to sum it up, let's pull our pieces of our puzzle together, get rid of the fragmentation, create interoperability, and allow us to function in peace in one day's time.
So Medicaid expansion's already been mentioned, right?
Yeah, but you can say it again.
Okay, no, that's fine. That and I do tend to agree with your comment just about the ability to share information more readily. This one's kind of one that was brought to my attention not too long ago, but we're certainly focused on it. But there are 7 counties in North Carolina that have opened up their public school playgrounds and walking trails to community members after hours on weekends. We think that should be everywhere across the state, just to improve access to have people have activity.
So I'm going to say an increased investment in early childhood so that every child enters school healthy, at a healthy weight, with good teeth, having had adverse childhood experiences addressed, with social and emotional skills so that they have the skills they need to be successful. Early childhood is critical for educational attainment and whether or not that child will graduate from high school. And the difference in life expectancy between someone at age 25 who has graduated high school and gone to college versus one who hasn't graduated from high school is 9 years. So I think it's a policy difference that can improve health across the state.
Great, thank you. I want to just take a minute or so to summarize some of the key points that I heard today, and then I want to thank our panelists. This was a great opening session. We really had a wealth of perspectives on what some of the key challenges are in the state. I think fragmentation is clearly an issue, but it sounds to me like we are making huge strides from when I heard Karen probably 10 years ago talk about some of the fragmentation issues we had there to what we're doing now, both in terms of moving towards better interoperability and also towards coordinating care that we're getting with this new models of care, and that there's been some great improvements in helping provide the supports needed for local practitioners to really be able to engage in this new model of care. From Steve, I heard a lot about the importance of really looking deeper at what is driving people into the health system so that we can address the underlying problems that people are facing that's causing them to come into the system, and really stepping back and saying the goal isn't to put people into hospital beds. The goal is to figure out what is driving their health needs and addressing that. And that may mean some uncomfort in our period of transition between the sort of different financing models that we have of fee-for-service, keeping a bed occupied, and value-based care, keeping people back in the community. But that it sounds like we are making great strides, and I am glad to be corrected about how much ahead of the curve North Carolina is in moving in those innovations. And from John, he emphasized the real point about addressing disparities, not just racial and ethnic disparities, although those are key to the whole population health in the state, but looking at geographic disparities, looking at access to food, looking at ACEs, adverse childhood experience, and that we need to focus in both at the local level and let communities sort of from the ground up figure out what is most important to them and get them involved in addressing their health problem, but also creating the policies for our state to enable us to be a healthier state, such as Medicaid expansion, although I'm sure it's not limited to Medicaid expansion, early childhood education as well. So I think you've heard a lot today that you will be hearing over the next day and a half about how North Carolina is at the front in many areas. We have still a long way to go, and how we have the wherewithal and the knowledge to really move our state forward in terms of improving health. I'd like to thank the three panelists for being here today and for setting the stage for us.